Welcome to another edition of Long Island Backstory. I'm your host, Gary Jacobs. This may be one of the most important shows that we've done so far with Long Island Backstory. It's a show that I believe is going to save lives in this half-hour segment that we're doing today. I have two guests here today. One is Dr. Cindambi, who came out from New Jersey today. The doctor isn't being paid to be here. She's an addiction specialist who has a unique program that we believe can be an alternative to the 12-step program and another option when the 12-step program doesn't work. The doctor is being here out of the goodness of her heart because I know she feels passionate that what she's doing is going to save lives. There's nothing else more important than doing that. Then we have to her left, Maureen Rossi, who's been a long-time advocate and actually introduced me to the doctor and introduced me to a seminar that she went to when I heard it. And I said, my God, how do we not have this doctor here on Long Island trying to save our children's lives with the heroin epidemic? Doctor, first of all, welcome to the program.
Thank you, Gary.
And tell me a little bit about, I want to get into the meat of what you do, but just really quickly, tell me about your education, what kind of doctor you are. I know you're an addiction specialist, but I didn't even know there was such thing as an addiction specialist doctor. I thought psychologists usually ended up doing this.
Okay, Gary, I'm a medical doctor. I have an MD degree. I came into this country and I got trained in psychiatry. And then I did my residency from Maimonides Medical Center and then went into NYU in the city to do my fellowship in addiction. I did 2 years of fellowship in addiction and then started my journey in New Jersey. So here I have my ASAM. Now they call it as an American Board of Addiction Medicine. So I have a double board.
So you're a smart woman.
Thank you.
Ah. So let me ask you, just what made you choose addiction? I mean, everyone chooses different fields, and usually you have a reason why you choose something. So what made you choose addiction?
There are two things that really, kind of pull me into addiction. One, the family history of having addiction. I come from a family where there is gambling a huge problem. We have lost people, and they have lost so much. The family itself because of gambling. So my passion towards addiction is deep-rooted. I want a quality of life for every person who is, living.
Addicted to something.
Yes, and you can still live with dignity.
Right.
It's possible, and it is a disease.
Right.
So I come to understand that. And the second reason why I'm in this field is because in my training years we didn't have, the training that we needed to treat any addicted population. So every time I stumbled into my residency with an addiction background, we had to transfer the patient. So that kind of made me feel, oh my God, I don't want an addicted patient in the ER, So I kind of went for further training. So now, when I went for my fellowship, I really felt that this is the field that
so it's your calling.
Fit into.
Because I got to think this is not like the best field for making money. I mean, you spend a lot of time in school. You can be a brain surgeon.
I work 7 days a week.
Right.
And there is no, job and life seems to be one thing. And when people ask me, how come you work 7 days a week? And I say, it's my passion. I'm not working.
There's a rumor that she sleeps with her cell phone in case she gets an emergency call in the middle of the night. Yeah.
And Maureen, what made you get involved as being an advocate for?
I've always been a child advocate. As a journalist, I've written for parenting magazines. So as I was raising my kids, I was just writing about the current issues of the day, and it just seemed natural. When I heard that we had a heroin on Long Island, back in 2004, 2005, I thought this is absolutely unacceptable. It was unacceptable to me, and it is unacceptable to me today.
God bless you for doing something about it. Now, doctor, let's get into the meat of why you're here today. Your program is different than the traditional program that everybody does now, and you know what, it works for some people, the program that we have now, that most people do, but obviously it doesn't work for enough because we've lost way too many children. One is too many, but it just keeps going on. Tell me about your program, why it's different. I know that's a big open-ended question, but
what's it called?
Go ahead and tell us about the name of your
outpatient ambulatory detox.
Outpatient, which is right off the bat. Isn't that different? Because traditionally,
it is 100% different.
Right.
In that, it's exactly the only way I can explain this is like you imagine going in an inpatient detox setting. The same exact treatment. You have nurses, you have medication in-house, you know, you have a doctor and you have therapy that goes on. We also bring in AA, into our facility, which is like the Alcohol Anonymous and the Narcotic Anonymous. So many people don't like the 12-step program because they think God, and I'm not a believer of God. So
especially
it's
going through, I would think going through some of this, somebody may say that there's no God. Why didn't let me go into this? So
but you offer that as well.
I bring in that too. Like you know, I introduce that in my center. So there is one AA or an NA meeting. So they kind of get to feel. No, it's not about God, it's about us, and all those 12 steps are important, whether you're an addict or not. One has to go through those 12 steps to have a quality of life. Making amends, for example. If you hurt somebody's feeling, going and really, you know, saying, I'm sorry, is part of life.
It's just good for everybody.
You know, like, you know, for everybody.
Right.
Like I make the, you know, patient feel it's not like you have to do AA or NA. If not, I'm not going to see that. There is no threat, you know, I'm not going to say you got to do this if not. That's not how it works.
Right.
You need to meet the patient where they are at, and then you work with them and make them feel comfortable.
Right. Doctor, this may seem blasphemous and, you know, 12-step programs are the holy grail. And oh my goodness, they're miraculous. For 80 years, they've saved millions of lives. And oh my goodness, really, they're wonderful. However, with this particular epidemic, over and over again, you hear parents second mortgaging their house. Third rehab, fourth rehab, fifth rehab, sixth rehab. It doesn't always work for this particular epidemic.
Sure.
So my thing when I met you was we need to use every tool at our hands, every tool we have. If someone responds to 12 steps, use that tool.
That's it.
Suboxone, Vivitrol, whatever tool.
See, one size does not fit all.
Exactly.
So we need to meet the patient where they are at. If a patient tells me, I don't believe in 12 steps, I'm not going to tell them, you have to follow 12 steps. But at the end of it, I tell them, that's exactly what you did.
Right.
And then they go, oh my God, and they go, you need to go for 12 steps. So it's like really, you know, you're not going with a power struggle with the patient. You have to have, here we are, as a treaters, we should be with an open mind. We should embrace them. We should be able to tolerate their behavior.
And I would think being an outpatient program is also an easier pill to swallow, I guess.
Yeah.
Because I know some people say, I don't want to, and you know, I've experienced this also. I'm not putting my child in an inpatient. There's a stigma attached to it.
Yeah.
Stigma
Maybe
and
the neighborhood,
shame, you know,
shame. But if they're home every night, all right, they're getting treatment.
You know, the most important thing is this. If somebody comes for treatment, if they are using the first feeling, they make a phone call to us and say, I would like to come in. And if I have to wait 2 days, those 2 days they're going to ramp up with the usage, and that could be
the end,
end of it. So before they want to come into a treatment center, they really get into, you know, want to use it. Yeah, that's exactly what, because I'm going to get better, why don't I use right now?
Like a bachelor party.
You know? Yeah. Exactly. So with our model, the minute they call, there is no waiting period. They could drive, come right in. We are open from 9 a.m. to 7 p.m. So they can make a phone call as late as 3, 4, and we call them, come right in.
Right.
So they get to see.
So you realize that you can't lose that window of opportunity.
No, because
maybe your only window.
That's the only window. And that window, when they come in, they see it's not non-threatening environment because you are not held against your wishes. You can walk out as and when you want, but I tell you what, it's very hard. We face a different problem in our facility. The patients don't want to leave. They love it there.
Right.
They love it there, and they say.
You said something to me before that I found unbelievable, quite frankly. You've been open for 2 years, and you haven't lost
not a single patient.
Wow.
There is not a single patient who ended up like.
Wow.
So somebody comes in, just take us through what happens. Somebody calls you up. They say, my son, my daughter, I just opened up their bag and I found heroin, and I had a conversation, and they said, yes, I'm doing heroin, Mom and Dad.
Gary, in order to answer to this question, you should also understand it's not just the pills, opiates. I also detox patients from alcohol and also benzodiazepine. When you say benzodiazepine, like Xanax, Klonopin, Valium, you know.
Very
popular ones. Like, you know, because you might see always it's a polysubstance use. A person might say, my drug of choice is heroin, but I also do Xanax because I'm anxious. That's been prescribed by a physician.
And when they can't get the heroin, they do the benzos.
Yeah, but that combination is deadly. You know, somebody might be doing 5 bags of heroin, just a milligram of Xanax. But that Xanax can really shut down on your respiratory center, and that's what you see most times. The parent walks into the room, the child is unarousable, and they're gone. And you know, the combination of benzodiazepine with opiate is not a good thing.
Deadly combination.
It's a deadly combination, and I'm telling you, having been practiced for so many years now, I really see how easy we have this combination that goes on. Not only that, even the psychotropic medication. People just put people on Seroquel to go to sleep. You know, you need to understand it's an antipsychotic medication. It has got endocrinal problems. One starts having excessive weight gain, and the lipid profile goes up, and eventually end up as a diabetic. So you need to be thoughtful about everything.
Doctor, you said to me, and this really struck, the first night that you and I met the doctor was at Tom Silmy's task force meeting, his first task force meeting, that opening your facility was like opening a hospital. So it sounds to me very different than a regular outpatient facility.
Correct. This is the, you know, I'm the only one who was in New Jersey, first licensed facility ever. I'm the only one who's doing, you know, detox at this level for the past 2 years. We started April 19th of 2013. Here we are, you know. And in all these 2 years, we have been detoxing patients from opiates, from benzos, from alcohol, from kratom, you know, and sometimes from the hospital, they'll send the patient saying that your insurance does not give you approval to be inpatient. And we don't know what is kratom. Just go to Dr. Cidambi's. She'll figure it out. I'm not like, you know, this has happened.
But how different, and that's like, so you have like a nurse on staff, you have psychiatrists, like how different is it?
Okay, let me explain what is this all about.
Yeah.
This is an outpatient setting. It's a detox. It's new model. Like in those days, you know, surgery, one has to go inpatient and get the surgery done. Right. Then they started doing ambulatory surgery. That's exact way, if I may, like, you know. So now we do the detox as an outpatient. Why should we do this as an outpatient? The driver is this. If somebody goes inpatient and they've been put in a bubble, so now you are taking that person who's using, putting them away, sending them away for a month, 2 months, 6 months, 8 months. So they've been sober for a quite good time period. And then they come back to their house, and you got to understand addiction well. They get into the same bedroom where they used to use. They lay on the bed and look at the wall, and they go, this is what reminds me of using. That's a trigger. We don't really get that. And then a parent might say, you came back from your rehab after treatment. What are you doing? Your room is not clean. You're not looking for a job. They take this all as a negative thing. And you and me might think, that's not a bad thing to say. But for an addicted person, this is like, you know, putting them down. The coping skill is not there. So they turn back to using. Right. This time they would say, I'm not doing too much. I used to do a bundle, which they call, right? Like, you know, 10 bags of heroin. Now let me really do 2 bags. Right. And then they go around to justify themselves with that. 2 bags, overdose, and they die. That's because the tolerance
over
the tolerance has gone down, and they don't understand, you know, that they can't tolerate 2 bags now. So
that's a big advantage to having.
Now with my model, they go home every day. They, you know, as I said, it's a mini
Even the
hospital.
first night, if they go in at 4 o'clock, they meet with you. You send them home that night.
That night, and you know,
what
most
if they're going
times
through withdrawals though?
We start them on medication, the first dose, and so we educate the parent what they need to do, what to look for.
So the family's
we have
involved,
the SAMHSA, you know, overdose toolkit. They sign, we teach them what to expect, and they sign after reading it, and you know, we are available to give them what to look for, signs and symptoms. So the patient goes home, and the next day morning they come back in. That shows you how motivated the patient is. You can't just get up and say, addicts don't want to get better. They want to get better.
Do they always want to get better?
You know, they have, truth to be said, when they come into our facility, they want to get better. The percentage differs. They might be 20% of them wants to get better, 80% of them still don't want to. They want to do maybe marijuana, you know, so maybe Xanax. I'm too anxious, I don't want to give up Xanax. Look at me, I've given up my heroin. So you need to really put it into perspective and say total abstinence is important, because the brain does not understand whether it's Xanax or,
And I think so many of us would be happy if our child came in and said, you know what, Mom and Dad, I'm not going to do heroin anymore. I'm just going to do Xanax, and I'm just going to drink, and I'm going to smoke pot. You say, oh, thank God, at least they're not doing heroin anymore.
But that's not good. It's only a matter of when they're going to go back into their own thing.
The disease doesn't know the difference.
Right.
It
So
doesn't know the difference.
So people need to be educated. You're involving the families in this. Now, what happens if somebody, say, gets arrested, and the judge says, hey, you either go to treatment or you go to jail? And they're going to you not because they necessarily want to get better, but because they don't want to go to jail. Can you work with somebody like that and
we do
turn their
work
mind
with people
around?
like that, and we call this a pre-contemplation stage of change. Meaning, I don't have a problem, the world says I have a problem. That's pre-contemplation stage of change. We take them from that, and all we do is stir the pot. So they start thinking, maybe I have a problem. That is the best.
Well, that's a big thing, because I think the conventional wisdom is nobody can do it till they bottom out, and you have to hope that they bottom out and don't die. Unfortunately, on heroin, too many people die. No. But that's the conventional wisdom, is people have to bottom out before they're ready to get better. And you're saying, no, that's not true. Get them in.
That's not true.
That's not true. Even if they are not willing to come for treatment, when the first time you bring them in, and we work with them. And we take away that stigma. We take away that question of whether I will be heard. In my center, my patients would say, I'm not a number. I'm here fully accepted. And I teach them to look at themselves and say, don't take a no for an answer. Look at your life, where it has really taken you down.
Yeah.
And I show them this is a fact of life. During my fellowship, we wrote a paper, music therapy and in addicted population, dual diagnostic population. Dual diagnosis meaning they have psychiatric issues and they have addiction issues. And what I learned, common. So I come to realize every addicted patient has something or the other with the artistic touch. So they either paint, they are into, they learn the guitar all by themselves. Such an intelligent and outgoing person gets addicted to this nonsense, and then before you see, they cut off from everything. They're all alone. They don't have no more friends. They can't keep up a relationship. The family is frustrated with their use, and so they start feeling that I'm a failure deep down.
And that's interesting. So these are smart people that have so much to offer. And of course, this is another sad thing about the society when I talk to the parents who lost their children, and they tell you about how special their childhood was. This could have been the next cure, the next person who cured cancer, or just so much good. It's because these are even the best of our. They're not the old. They're bad kids anyway.
Yeah.
This is the best of our society.
You and I talk about this all the time. In the last 10 years, I have met the best families I have ever known in my life. Maureen, we've gone to church or synagogue, or my husband coached his team, or I was her Girl Scout leader. We ate like a family. We went camping. Best people you ever want to meet. It knows no boundaries.
And when parents say, where did we make a mistake? It's not the parents. I'm
going to have to go through some of these really quick because we don't have that much time. It's so important that we have to get it all in. First of all, does insurance cover your program?
There is, close to zero denial for our level of care.
Good.
So we
that's
always,
a big hurdle right there.
When a patient makes a phone call, we can take them in.
And listen, just common sense says that if insurance is paying for it, they got to think that number one, it works, and number two, it's cheaper than the other options because they're not looking to pay for these
Any private insurance we take, it's Medicare and Medicaid are the only ones that we don't work with. We tried.
Well, somebody has to pay. If somebody says, look, I don't have the money and they have to pay. What are we talking, $1,000 a day, $2,000 a day?
No, not at all. It's not.
What's the range?
Hold on to your chair tight. It's $400 per day for a detox. So that includes 2 meals, a snack. They have the refrigerator and the snack right there. They can help themselves with everything. Plus therapy, medication. We give Suboxone and Librium, and you call all the detox medications. But if they are nauseous, we give them the medication. It's exactly like everything goes
like
under that
hospital.
For $400 a day.
You can't even get a hospital bed for $400 a day.
Exactly. You go. And I'm telling you, in order to get sometimes Suboxone, you're paying $400 for an hour to see a doctor. So this is like, you can't even put dollars to this.
It's incumbent upon the insurance companies
to do this.
And you
to support a situation that was A, this successful, and B, this cost success.
Right. Well, I think, that you haven't lost anybody is
Not
just,
a single patient
amazing.
Just
has,
thank God, that's
you know,
that's just
been,
unbelievable.
and also like when I detox patients from alcohol, never had one seizure. Not a single patient has been through seizure, no stroke, nothing. And in the initial stages, we used to at least transfer patients to emergency room, not anymore.
You're
We
comfortable.
take care of everything under our
Now, do you get
roof.
people who have gone through these other programs that we have, and they've you know, come back and done drugs again, and 2, 3, 4, 5
Failures.
times that they don't work, and then they come to your program? Do you take them and let's talk numbers, because people could be watching the show saying, well, that's great that it's inexpensive, but does it really work? What kind of numbers are we talking? And let's put it in perspective to
Right.
the 12-step program and how their numbers work, because this isn't something that, boom, you go to a program 100%, they're done and they go home. And
Right.
unfortunately, it's not.
No, we take patients who have failed several treatment, inpatient treatment, outpatient treatment. It doesn't matter to us. If they come to us, we take them, we work with them. You know, our success rate is pretty high. In those 2 years, I can easily tell you, like, you know, my patients, so far we have detoxed close to 480 or so, give or take. You know, 1/3 of them or a little more of them are benzodiazepine and alcohol. So of all these patients, majority of them go follow through, meaning they do the detox 7 to 12 days, depending upon what drug they do. And then they step down to PHP level of care. That is the partial hospital program. So when they do detox, they come in at 9 o'clock and then they leave home at 7 o'clock. And then when they are starting the PHP program, they come at 9 and they leave by 3 p.m. So why is the difference? And they come only from Monday through Friday
For how long?
partial, 2 weeks. Why do we have that? To address two things. One, we teach them, like, you're here in our center from 9 to 7 and then you go home, you did not relapse. Now we are slowly walking them through until 3 p.m. you're here and you're able to go take care of your business and then come back next day morning at 9 o'clock. And if you really notice this, when they are in detox, they are there Monday through Sunday and there is no break.
Right.
But once they are in PHP, we are now teaching them to be there during weekends and have their, you know, community activities that they do. And if they continue to remain sober, or if they have a relapse, if not to the drug of choice, something else. Oh, I felt, you know, I was there with my friend and I had a beer, or I had a, you know, joint with my friends. So we address that. We talk to them. We make them understand why that's not a good habit. So they go from Monday through Friday, 9 to 3, and then once they complete those 2 weeks, it's also very important to have the PHP level of care, because most times after detox, patients really feel good. They go home, 2 days later, they relapse because they started having post-acute withdrawal symptoms. They are still under discomfort. When an opioid patient really feels, you know, not comfortable, they have this fear of having full-blown withdrawal symptoms.
Right.
That's
So they
a
don't want to hit that.
horrible feeling. So they go back and use.
The fear.
The fear of, you know, going through that withdrawal really puts them back. So this PHP level of care helps them, you know, go past that. Once they do that successfully, we kind of refer them into the community to an IOP, which is an intensive outpatient treatment.
Intensive
And outpatient treatment.
Okay.
And I tell my patients, 90 days of being sober really changes the way
So
you look at
that's
life.
a big goal to
Big
reach
goal
that.
to reach that. And this going all through those 3 stages of treatment makes them quite successful. And after 90 days, if there is a relapse, that's, you know, that's because the lifestyle has not changed.
Right.
And so
Have to work
that's
on that.
very important for them to
Well, I
work
think,
on
you
that.
know, we've seen, and I've read a lot of your papers, and unfortunately we can't get into all of it here today because we're limited on time. But you know what? Your program, it works. It's another option, and we really need to make it available. And people could be watching this show. We need, I don't know why people aren't begging you to do it here. We have facilities here on Long Island. We have empty buildings that the county owns. I'm asking anybody who's watching this, go to your legislator. Let's take one of those facilities. Let's give it a try. We have nothing to lose but lives. Let's give it a try. Let's take one of these buildings. And Doctor, we talked before the show, and I asked you how much it would cost to take one of these facilities and say, for a year, let's open up one of your facilities here and let's use it as another option. And I thought you were going to come back and tell me $5 million. You said, Gary, $500,000 to $750,000, we could have a program.
Right.
Let's get our legislators to give this a try. We throw away money on so much crap these days. This is our children's lives. Come up with the money. Our legislators need to come up with this money and do a facility. One of the things we talked about, though, because legislation takes a long time and politicians, unfortunately, don't move very fast. One of the things we can do, and we discussed this, is get a bus. You're in New Jersey. Get a bus that drives 7 days a week, that meets somewhere, exit 50 on the expressway, and we drive to your facility on a nice, comfortable bus. They have lectures on the bus, so they're not just sitting there bored. They learn on the bus. That's part of the treatment. They learn on the way back. They're home every night. And we talked about something like this costing less than $200,000, and we could do it. I'm asking this is a plea. I'm begging anybody who's watching this. If you want, people make charitable contributions all the time. This is a charitable contribution that you can make. Sponsor the bus for 6 months. If you're a corporation, if you're just somebody who lost a loved one and wants to make a difference, please sponsor this bus. You will be responsible for saving lives. Once we can prove that this is done and we can say, hey, my child was saved because of this bus going to New Jersey, then that'll be an easier step to go into the next level, which was you open up a facility here on Long Island.
Definitely.
And we save lives. So
we need a facility. We
need
your facility here.
We need another option. We've talked about that people keep doing the definition of insanity. He's doing the same thing over and over again and expecting a different result. We keep going into these programs and they don't work, and parents have nowhere to turn. They have you to turn.
It's not the program that doesn't work. I have to correct that thing. The program is the same. The treaters are the same, but the problem is just that alone doesn't cut it. Right. You have to teach them to live in their own living environment, which is a stressor. Right. It's like, I keep saying to the patient, this is like a pacifier. When they have stress, they're going to turn to the pacifier, which is drug.
Not everything works. Like, not everything works for everybody. Different personalities, but you bring a fresh approach to it, and I know you can save lives and be another option and give hope. Dr. Cindambi, thank you very much for coming out here. Appreciate it, Maureen, as always.
Thank you, Gary. Thank you
very much.
Thank you, Doctor. Always a pleasure.